thank you all for having me here to talk to you today. I'm going to go ahead and share my slides, and I'm going to be talking about delusions and hallucinations in dementia. Now, I will be using a lens of Lewy body dementia to sort of point out where things are similar or different, but I'm taking a fairly broad view of these symptoms that can be seen across, as you'll see, essentially all forms of dementia. I'm at Wake Forest School of Medicine, and I guess now I have to say Atrium Health Wake Forest Baptist for the clinical piece of things. And then I am the clinical core co-director of our Alzheimer's Disease Research Center here at Wake Forest. This is a picture of me with Dan Coffer. He was my first mentor in residency. I did my residency at UNC while Dan was there, and his loss was just, it was unexpected and devastating for the dementia community in North Carolina. For anybody who had the pleasure of knowing him, he really did have was passionate about caring for patients and caregivers and helping people with very complicated symptoms. I am a federal employee part-time, and so just as a standard disclaimer, these are all my views. They are not the views of the Veterans Health Administration, Department of Defense, or the United States government. So we're going to talk about some common language. Now, some of this is, the first short part of this is going to be, the content's going to overlap some with what Dr. Bazzochi presented, a little bit more general and not as much focus on Lewy body dementia. I just want to make sure that we all sort of have a good working knowledge of some common terms. And we're going to talk about types of delusions and hallucinations, how common they are. And then I think one of the more important pieces here is, what's the evaluation for psychosis in dementia? What do you do when a loved one who has dementia suddenly develops psychosis? Then we'll talk about treatment, both meds and non-medication options, and then how we monitor a response and can hopefully work as a team to achieve the goal of improving quality of life. As we age, we all have some degree of cognitive aging. And my first step when somebody comes in to see me is to try to determine, is there anything more than I would expect with age-related cognitive changes? When there are, meaning that we can measure with some tests lower scores on memory or other thinking tests, and then someone's concerned about it. And that can either be the person with the symptoms, that can be a loved one, or it can even be a doctor that's known them for a while. So if there's a concern and low scores on the test, and then there's no decline in the ability to perform daily activities, that's what we refer to as mild cognitive impairment. Now, mild cognitive impairment in some small number of people will get better, and that's if it's due to something like depression or stress or sleep apnea or medications, it could improve. And another group of people, it may stay stable over time. And then probably in around 50%, give or take, depending on the study, mild cognitive impairment does represent a pre-dementia stage. Dementia means sort of the same things there, with someone has a concern or about changes in cognition. There's low scores on tests of memory and thinking, and it's enough to impair daily activities. And in the mildest stages, we see impairment in things that are required for living independently. So driving, cooking, cleaning, paying your bills. As dementia progresses, we see basic daily activities impacted, and these are things that are important for meeting one's physical needs. Things like feeding, dressing, and personal hygiene. And then finally, at a severe stage of dementia is when someone might be fully dependent on others to provide care for them. Alzheimer's disease is going to be the most common form of dementia that we see. And that's true both in late onset as well as earlier onset cases. Anything before the age of 65, we consider early onset dementia. The typical presentation here starts with short-term memory loss. So this is when most people think about common older age dementias. Alzheimer's disease is often what they have in mind. The typical presentation is that, but it's important to know there are unusual presentations of Alzheimer's disease, especially in younger individuals before the age of 65. It's more likely to start in places other than short-term memory. And the symptoms can vary by the severity of dementia. So, and in addition to the cognitive changes, the behavioral symptoms, the things outside of cognition, can vary. And so early on, we might see depression, anxiety, loss of motivation, irritability. And then later on, we tend to see more delusions and hallucinations, sleep and appetite changes, and then agitation becomes even more common. Now, there's exceptions to all of those rules. Certainly, there are people that present with very early delusions and hallucinations, often delusions with Alzheimer's disease. And we'll talk about what that tends to look like, because what delusions people come in with often varies by how severe the disease is as well. Lewy body dementias, Dr. Bozzocchi did a much better job of going over this. So this is going to be a very brief reminder that Lewy body dementias are the second most common neurodegenerative dementia. The terminology here it can be confusing. And so when we say Lewy body disease, we're sort of referring to these two categories of Parkinson's disease and Lewy body dementia. And to make it even more complicated, if you flip the words around, there's a specific subtype of Lewy body dementia called dementia with Lewy bodies, where the memory and thinking changes present before or within a year of those movement changes that are of Parkinsonism. When someone has Parkinson's disease for a long time, at least a year, but it's often longer, and then develops dementia, that is often referred to as Parkinson's disease dementia. Now, what this looks like is different than your typical Alzheimer's disease. Memory is often relatively spared, or at least the type of memory that you see impaired is different than in Alzheimer's disease. There's more problems with spatial cognition, being able to see things properly and reason with that things that they're seeing, and then difficulty with multitasking and concentration. Hallucinations here are one of the core diagnostic criteria for dementia with Lewy bodies. Now, it's a core criteria, but it does not have to be present. So just because someone doesn't have hallucinations does not mean that it can't be Lewy body dementia. Frontotemporal dementia is made up of 3 different variants, but you can kind of separate them into behavior and then the language variants. The language variants here are going to have much less behavioral symptoms early on, and these have very prominent language changes. Behavioral variant frontotemporal dementia is, as the name suggests, has a lot of behavior changes. So loss of sympathy, socially inappropriate behavior, severe apathy, craving carbs or sweets, or having ritualistic behavior, doing things in a very stereotyped way. Now, in behavioral variant frontotemporal dementia, as I said, the behavior changes are often more prominent and challenging. Misdiagnosis here is really common. People are not infrequently misdiagnosed as having bipolar disorder or even schizophrenia. And then after a period of time, it becomes clear that it doesn't fit with that. And then someone is able to diagnose frontotemporal dementia. At the same time, there's misdiagnosis that runs in the other direction, where people are told that they have frontotemporal dementia, and they may show up to my clinic 3 or 5 years later with really no progression of their symptoms, and with a reevaluation, it doesn't look like they have frontotemporal dementia. And that's because it's a tough disease to diagnose, especially without biomarkers. And so I'm always cautious with any of these diagnoses to try to work through it myself, confirm what other folks have said, and try to arrive at what I think is the right diagnosis. Apathy here is really common. It's present in over 3/4 of individuals. Psychosis, meaning delusions and hallucinations, is rare, but it's more likely in some genetic variants of frontotemporal dementia. And this is compared to dementia with Lewy bodies, for instance, where the hallucinations and delusions are much more commonly seen. So this is a list of many of the behavioral symptoms we tend to ask about in a memory disorders clinic. And so you'll see that it ranges from things like depression and anxiety and irritability to delusions and hallucinations. Now, taken together, delusions and hallucinations can be referred to just broadly as psychosis. And psychosis here means that individuals have difficulty testing their reality. And so the things they believe or see are not consistent with the reality that everyone else is experiencing. So delusions, what do we mean by that? And what's really important about delusions is that they're fixed and they're false. And this can present in different ways: stealing, someone's harming them, misidentifying people. The key is it has to be it's fixed, and it is not going to change based on evidence. This is not about just finding the right evidence to convince someone. Hallucinations are perceiving things that are not there and that do not have anything that they could be misperceiving, right? So hallucinations are often contrasted with illusions. An illusion means that there's a sweater on the floor and you look down and you think it's a dog. A hallucination would be seeing a dog where there's simply nothing to perceive as a dog. It's there without anything to as a stimulus. Visual hallucinations are the most common ones that we talk about, in part, I think, because they're the most readily apparent to us. When people say there's somebody sitting on the couch right now, you can pretty well look and see that there's not someone sitting there. So your visual reality is shared with someone else. Hearing is kind of the same way. We don't see as much isolated auditory or hearing hallucinations in dementia, though it can happen, and it frequently occurs along with the visual hallucinations. Now, there are other hallucinations as well. So feeling things that are not there, smelling things that are not there, all of those can occur. They're a little harder to for people to identify as a hallucination. So if somebody's feeling something, well, you don't share the same felt reality of your skin, right? That's that person telling you that they feel this thing, and you have no way of feeling it, right? So it can be a little trickier to disentangle what's going on there. The hallucinations themselves can be quite simple. or they can be quite complex. So ranging from shadows out of the corner of someone's eye to seeing children playing in the house. And the degree to which someone can appreciate that these are hallucinations varies as well. Sometimes people have some intact insight, or sometimes it's just after the fact, where they're able to say, well, yeah, my spouse told me they're not there, so I believe them. But often in the moment, these are sincerely perceived things that seem every bit as real to them as you watching this webcast right now. Delusions come in a lot of different types, and the more common ones that we see, there's persecutory delusions. So these are really common early on, more common in Alzheimer's disease early on. These are fixed false beliefs of harm, impending harm, that someone is being poisoned, drugged, conspired against in some way. Kind of closely related to theft, where theft is a delusion of theft is that someone's valuables are being stolen, often by an unseen thief or maybe a caregiver who comes in. And this can sort of overlap with if someone can't remember where they put something, developing a delusion that someone is stealing it may make the most sense internally to their brain. There are, those top two are a bit more commonly seen in Alzheimer's disease. Now, some of these misidentification delusions are more common earlier on in dementia with Lewy bodies, but can eventually develop in Alzheimer's disease as well. There's really none of these things that I'm telling you about. There's not a single one that could only ever be seen in Lewy body dementia or in Alzheimer's disease. It has more to do with understanding the time course, where someone is in their illness, how long it's been going on, and you can see them in different places in the illness. So it's unfortunately, there's not sort of a simple, this is there, so it must be this diagnosis. With that said, Capgras delusion I see much more commonly in Lewy body dementia, especially in earlier stages of the disease. This is the belief that someone's often spouse or relative or someone they're quite close to has been replaced by an imposter. Now, people are not going to tell you usually, oh, you're an imposter. They'll say things like, well, I'm waiting for the real John to come back, when John, their spouse, may be sitting right in front of them. And so they may act as though they clearly don't believe that person is actually their spouse, but they think they look like them and they're an imposter. A phantom boarder is another fairly common delusion. This is when a stranger, usually unwanted, is living in someone's home that's not really there. A mirror self delusion is one that is seen more often in advanced dementia. This is where someone might look in the mirror and they think it's somebody else. They can't identify that their reflection is the self. And then finally, reduplicative paramnesia, which is kind of a big word that basically just means a thing has been duplicated. I often use this in relationship to someone's house. So people will say that they need to go home. This looks like their house, but it's not really their house. And that would be an example of that. Hallucinations, as I said, can be in any sensory system. There's very simple things that are almost barely a hallucination, where people, especially in Lewy body dementia, will say that they feel a presence with them, and that presence will sometimes even be described as being seen behind them or seen out of their field of view. Get up, from that a little more concrete is someone will see shadows in their vision. And then more classic would be seeing children, animals, or insects, well-formed hallucinations. These frequently move, so they move around. They may talk, especially in Lewy body dementia. It's more common to have a spoken or an auditory component to the visual hallucination. There's often not a day or a nighttime pattern, with the caveat that this can occur when people experience sundowning or the confusion that may occur due to day-night circadian disturbances later in the day. You can see hallucinations. And as I said, some people retain insight, others really completely lack any insight that these are hallucinations. So it depends how common these are. Psychosis and cognitive disorders really depends on the exact diagnosis and the severity. So in mild cognitive impairment, before someone has functional impairment, hallucinations and delusions are pretty rare. Now, that being said, if you remember the discussion of prodromal Lewy body dementia, certainly it would, if somebody came in with mild cognitive impairment and had visual hallucinations, that would be something that really clued me in to be thinking about prodromal Lewy body dementia. Delusions I have seen both with Lewy body dementia and, or prodromal Lewy body dementia and prodromal Alzheimer's disease. Now, in Alzheimer's disease dementia, you can see here in these bar graphs, so you'll notice that by and large delusions are more common, except in Lewy body dementia when I show you that. So in Alzheimer's disease, about 30% of people with delusions and just under 20% with visual hallucinations, and a pretty low rate of auditory hallucinations. Now, early on, the persecutory delusions are more common. Misidentification occurs later. Lewy body dementia, that flips so that you see more common visual hallucinations. Auditory hallucinations go up as well, and then delusions are more common, but they're less common than the visual hallucinations. So if you look in Alzheimer's disease, delusions are the most common, but in Lewy body dementias, you see visual hallucinations become more common. In frontotemporal dementia, as I said, it's rare, but hallucinations do occur, delusions as well. And then vascular dementia looks very similar to Alzheimer's disease in terms of the rate and frequency of those delusions. Now, before we talk about treating and how you address hallucinations and delusions, it's really important to drive home this point that sudden changes are critical to recognize. And so when somebody has a sudden change in mental status, that can mean a delirium, and a delirium can absolutely provoke hallucinations and delusions. So things that can cause a delirium can be a change in environment, poor sleep, medications, which we'll talk about, or an illness. So for my patients with dementia, a sudden change in mental status can be as important as a fever to signal that they have an infection. Delirium is a sudden onset over hours to days. It fluctuates, and so it's not just the fluctuation of, well, they had a good day or a bad day. The fluctuation is usually they will be very inattentive, unable to maintain focus on you at all, and then at other points may be much more like themselves. You can see this after surgery as well as a provoking factor. And as I said, these are common with delirium. So the first thing that I need to think about when somebody comes in with hallucinations and delusions are that this could be the sign that there is a delirium, which is important because it's potentially treatable and partially or fully reversible, depending on what the cause is. the very first thing is safety. If somebody is floridly hallucinating, delusional, could harm themselves or others, they are not safe and they need to go to a hospital, and they may need to be hospitalized in a psychiatric unit, which may be the right place for them, or they may need a medical unit to treat what's causing a delirium. But safety is the first thing, because people can, if people are not thinking and processing and perceiving correctly, they could harm themselves or inadvertently harm someone else. The physical causes are the first thing that we have to think about. So could someone be in pain? Could they have an infection? Could they have sensory problems or poor sleep that could be provoking this? Could it be a medication that is driving their delirium? So there's a lot of meds that can cause problems, and anticholinergic medications are probably the biggest class, the biggest offenders. And there's a lot of them. This is an example of a pocket card that a geriatrician or a neurologist may have that would tell them, here's all the list of drugs that have these anticholinergic effects. Sometimes there's a reason to be on them. So it's not that someone can never be on them, but it's that you have to consider that it's a potential side effect. And it has to be weighed with how someone responds to it. So this is my only picture of the brain in a lecture, which is pretty good for a neurologist. And the only point here is that, so these blue circles are areas of the brain that produce acetylcholine. And the most important thing to take away from this is that it projects everywhere in the brain, right? And so some of the dementia medicines like donepezil, galantamine, or rivastigmine, they help promote more acetylcholine in the brain. But anticholinergic medications reduce that. And it can cause delirium because you're affecting essentially how the entire cortex is processing information. And so these drugs can be really problematic in people with dementia. If we look at some more common ones, you'll see here in the cold medication antihistamine category, Benadryl is quite notorious for doing this, but there's a whole list of other ones there that can do it. Bladder drugs are frequent prescription meds that can cause problems. So oxybutynin or tolterodine, which is Detrol, can cause problems. And so sleep aids are a huge problem. They are over the counter, they're common. You just go into any pharmacy and you can pick up Benadryl or doxylamine in a number of different formulations. And I would rather have a prescription medicine that I'll talk about a bit later in any of my patients with dementia than taking these medicines. Antipsychotics. Now we're going to talk about antipsychotics later. And, here I am telling you that they can potentially be a problem, and they can potentially be a problem, but depending on how the symptom presents, they might still be the correct thing to try and use to palliate a symptom. Motion sickness drugs, dimenhydrinate or meclizine, are common offenders for this. They don't work very well anyway, for the most part. So to try to boil all that down to what I see as the most common offenders, anything with PM behind it is often a problem. Benadryl, NyQuil. For sleep and allergies, I would rather use trazodone, which is a prescription sleep aid, or I would recommend that folks use Claritin, which is not perfect, but it is certainly less likely to impact the brain than Benadryl. Benzodiazepines people may be on for anxiety or sleep. For sleep, you see up here, I would tend to use other options, and then Buspar for anxiety, or a selective serotonin reuptake inhibitor. For oxybutynin, there are options for incontinence that have less cognitive side effects. I might try vestibular rehab if somebody has frequent vertigo to see if that can help. For antidepressants, really most of the modern SSRIs are okay other than Paxil. Paxil can be a real problem. Paroxetine is quite anticholinergic. For muscle relaxers, I may try heat, physical therapy, things like that. And then for stomach cramps, these are things like icosapine or dicyclamine. Sometimes just modifying the diet or a good bowel regimen can be enough to not have to use those drugs. Now, if somebody's been using one of these medicines and it has a good effect and they come in and they're on it, I'm not necessarily going to try to change it immediately or take it away. But that's very different than if somebody comes in and they just started Paxil for some mild depression, and this week they are hallucinating, right? So I've got to think about when and in what relation to these medications do the symptoms begin. So benzodiazepines and zolpidem, commonly called Ambien, almost always a bad idea. Can cause falls, worsening cognition, pneumonia, delirium, and psychosis along with that delirium itself. There's exceptions to every rule, and so it's not that I never use benzodiazepines or Ambien. Short-term crippling anxiety and panic, severe REM behavior disorder. Yes, I do occasionally use those medicines. If people have been on these drugs for a long time, I cannot just stop them immediately. It's going to cause a problem. It's going to be a slow taper over often months to successfully get folks off. This is a picture that I like when I try to explain why benzodiazepines and Ambien might be a problem. This is just showing the receptor that they work on. And so if all you take away from this is that the benzodiazepine circle binds to essentially the same area that alcohol does when you drink, you can understand how it might cause cognitive worsening and falls and the like. So when we're diagnosing psychosis, sometimes it's difficult to tell whether it's truly a delusion, or maybe it's just a memory problem. Maybe it's that somebody cannot remember something, and so that's what they, that's their recollection. Delusions are often persistent and they don't go away. So if it's just a temporary thing that's different the next day, that might suggest to me that it's a memory distortion. But there's no perfect test for that. Is it a hallucination, or is it a sensory processing problem in advanced dementia? Certainly illusions might be one example of that sensory processing that can occur. And that's related to, but different than a hallucination. And then asking about hallucinations and delusions can be tricky. Interviewing someone's caregiver is often easier to figure out what's going on. If I am asking about hallucinations and delusions, I often don't get the right answers if I just go in and say, well, do you see things that aren't there? Or do you believe things that are not true? So I will ask about unusual experiences or any things that they see that other people can't seem to see. Any special things that happen to them, any things that are bothering them. Often that will come up. That will bring out those delusions. Here's an example of a questionnaire that we use. This was developed by Dr. Kauffer when he was a fellow working with Dr. Cummings, and this was a questionnaire based off of a longer interview. And this is something that I may do to both initially assess, but also monitor hallucinations and delusions over time. So the first thing is it just asks, are they present? And if they are present, how severe are they? Mild, moderate, or severe? And how bothersome are they? And the distress scale was the thing that Dr. Kauffer added, because it turns out that distress, how much the symptom bothers the person taking care, how disruptive it is a big predictor of So the behavioral symptom is itself a big predictor of distress, more so than cognition. 61% of symptoms are moderately to severely distressing, and those distressing symptoms predict placement outside of the home much more than cognition does. So if we're going to treat this, so let's, first, as I said, we're going to determine, the first thing is safety, and really I should say reversible causes. If somebody's hallucinating or having delusions, the first thing after safety is reversible causes. But then let's say we've ruled out delirium, we've ruled out something that can be treated, and we think that the psychosis or the delusions and hallucinations are simply related to the dementia. So if that's the case, one question that we have to ask early on is, do we need to treat the symptom? And we'll talk about, why we may or may not. Third, we want to engage in some non-medication options. And then finally, fourth, we try medications. And depending on the diagnosis, as I'll highlight, particularly with Lewy body dementia, it can impact the medications that we choose. So not all of these behaviors are necessary to treat. Now, it may seem a little off-putting at first to think, but someone's hallucinating. My goodness, why wouldn't you treat them? Well, you wouldn't, because the treatments are not without cost. Everything that we do or don't do has some cost associated with it. So every medicine has a side effect and risk. And so if these are not harmful, they're infrequent, people can be redirected, it's not causing distress, the best thing to do might be to acknowledge that someone's having these symptoms and then to choose not to treat them. Medications may also not be effective for certain things. If we take something like verbal aggression, you'll see here, some things are responsive to meds and some are not. So psychosis can cause aggression, right? So if, we may need to try to treat that psychosis if it's causing aggression. Non-medication approaches are really important to try first. Now, there's really not much evidence that non-pharmacologic or non-medication strategies will improve the psychosis. It's unlikely to make the hallucinations go away, but it may improve the behavioral symptoms that go along with it. So if somebody's agitated because of that hallucination or delusion. So first ground rule is you cannot argue with a delusion or a hallucination. You're unlikely to be able to convince somebody that it's not true. And 9 times out of 10, it's just going to make the person experiencing the hallucination or delusion and you more frustrated and angry. So you try not to confront or argue about it if you can. Provide simple answers to what's going on. Try to switch an activity. So if somebody's really focused on seeing something outside, you may be able to get them to go into another room to help you with something, and then 10 minutes later, that delusion or that hallucination may be gone or improved. Modifying the environment can help. So if there is something triggering the psychosis, remove it. So if it's a mirror, that mirror self delusion, cover the mirrors. If it's a particular thing that's provoking it, try to remove that thing from the environment. And in terms of what to say or do, if you can address the emotion and not the delusion, that's helpful. Because you can't just ignore someone's distress. So if somebody has a delusion of persecution, they're fearful about someone harming them, you might say that, well, I see that you're really frightened. I want you to know that you're safe here. I'm going to help look after you, and try to address that rather than the delusion itself. Now, all of this is really easy for me to say, sitting in my office with a PowerPoint or sitting in the clinic talking about how to address this. Living this day to day, moment to moment is so much harder. And so the resources from the DANC, Pat Snyder's videos, the other videos they have about problem solving and how to work through dealing with these things are time well spent, because certainly a few bullet points on a slide cannot prepare someone for doing this day to day, moment to moment. So antipsychotic medications will invariably come up if somebody is experiencing psychosis. These are all repurposed with one exception that I'll show you from other drugs and for behavioral diseases such as schizophrenia and related disorders. There is an established, if statistically small, benefit across groups. In some people, I've had great success, and other people I don't seem to do much good at all. There is a black box warning for all antipsychotics in dementia-related psychosis. So this is for risperidone or risperidone, and there is an increased mortality in older adults with dementia-related psychosis using this drug. And yeah, initially there were arguments about, well, maybe it's just that you're having to give it to people that are more frail, and so they were higher risk to begin with. I've been pretty well convinced by some of the data looking at controlling for that this is a real effect. This does increase cardiovascular, probably cardiovascular mortality through some effects on the heart. Certainly, lots of people take these medications. I use them, and I always discuss this black box warning, and we discuss it in terms of a palliative approach. So the goal is to reduce distress, increase quality of life, and if a medication does that with an increased risk that we accept, then we are going forward with eyes open to that. At the same time, if we try the medicine and it doesn't help, for goodness sake, stop it. Which medicine gets used depends on the diagnosis. So in Alzheimer's disease, aripiprazole and risperidone have the best evidence for effectiveness, more so than quetiapine, and there's virtually no evidence for olanzapine, though I've seen it used before, and certainly anecdotally I've seen people have an okay response to that. Except in rare or acute circumstances, I avoid Haldol or haloperidol, the older medicines. It has a place in severe agitation, but the risk is higher. Now, in Lewy body dementia, there's a particular sensitivity to these antipsychotics, and it can make people confused, worsen their Parkinsonism, or even cause fatal reactions with certain medications like haloperidol. And so based on the pharmacology of these drugs, quetiapine is usually the first one that we use, and we use it at a really low dose. To give you sort of a framework, we're using it at 12.5 to 200 milligrams per day. The typical starting dose in schizophrenia is 200 to 300 milligrams per day, and doses of 800 milligrams per day are not unheard of in schizophrenia. They are quite unheard of in dementia for the most part. Side effects here are drowsiness, confusion, weight gain, the cardiac arrhythmia because of an effect on the conductance in the heart, and rarely it can cause a Parkinsonism. Clozapine is another medicine that's rarely used. I can prescribe it, but a lot of folks don't go through the process of being able to, because it's kind of a pain. You have to check frequent labs, and it has some terrible sounding side effects that are rare. So I will say I was struck by this. This was from a Lewy body dementia caregiver, and this was from a paper that talked about, sort of less commonly used medications in Lewy body dementia. And for this particular caregiver, risperidol was what worked for them. And so would I normally give risperidol in Lewy body dementia? Goodness, no, of course not. If we've tried everything and the distress is terrible and the symptoms are just making the patient's life miserable, would I consider trying it cautiously at a low dose? Yes, I would, though only after trying to exhaust every other option. An additional point about Lewy body dementia is cholinesterase inhibitors. These are your donepezil, rivastigmine, and galantamine. These are really important in Lewy body dementia to get patients on if they can tolerate them, because they can improve psychosis and global neuropsychiatric burden. Now, for many of the same reasons that Dr. Pizocchi pointed out with the lack of trials now, this is not FDA approved for Lewy body dementia. It's approved by the in Japan for treatment of DLB, but not in the US. So it is off-label, but I've seen anecdotally the best effects to these medicines in patients that I think have Lewy body dementia. The side effect profile is much better than antipsychotics. And if tolerated, this is the one diagnosis where I'm willing to try to go above 10 milligrams daily of donepezil up to in effect 10 milligrams twice a day. Side effects are much more problematic then. Not everybody tolerates that dose at all, but I will consider it if it's been helpful in Lewy body dementia. Side effects here are going to be heart rate slowing, passing out, diarrhea, and nightmares. And that's much worse usually after the 10 milligrams. Some of you may have heard about Nuplazid, or pimavanserin was approved to treat hallucinations and delusions or psychosis in Parkinson's disease. Seemed great because didn't have the nasty side effects of increased mortality. But then it turned out that, well, it may be associated with some increased mortality since its approval in April of 2016. There was one trial that looked at the mortality of Parkinson's psychosis treated with pimavanserin versus untreated, and treated with pimavanserin was lower than untreated Parkinson's psychosis. Now, this drug is very difficult, if not impossible, to get outside of somebody who has a diagnosis of Parkinson's disease. So if I make a diagnosis of Lewy body dementia or dementia with Lewy bodies, I'm not going to be able to get this medication covered. I've been rarely successful. And this is why that sort of makes it a non-starter, because this is a very expensive medication. This is the group GoodRx coupon price. If I can say someone has Parkinson's disease dementia and Parkinson's disease psychosis, this is a potential medicine to try. If I can't say that, this is just not going to get it covered. When we're monitoring response, the gold standard here, I often have people ask me, well, like, okay, when are we going to do a brain scan? When are we going to do something high tech? And the reality is the gold standard for managing most of this comes down to me asking you, how are things going, right? Are they better? Are they not better? And I can do this in a more formalized way with a questionnaire, but that's really what tells me if this is working. So you're going to tell me if it works. The best practice with antipsychotics is to attempt to reduce the dose or titrate off. This is only for the antipsychotics. And so we may try that, and sometimes it may not be possible, and that's okay. We go back on. Complete resolution may not be an achievable goal. It may not be that we can realistically get someone to not have any hallucinations ever. That's what we'd like to do, but we may be able to make incremental improvements and not a total cessation. It's always worth reconsidering the treatment. So, my patients that see me will hopefully would vouch that, I'm always willing to reconsider how things are going, or did that medicine work, or did it not work, and change course if we need to. And sometimes stopping the medication leads to overall improvement. I've had patients that I have just tried everything I know how to do to treat the psychosis. And along the way, we were probably giving them side effects and making things worse. And then when we just said, okay, you know what, it's not working, let's just stop, reset, things turned out to be better off of the medication. And so sometimes the right thing to do isn't to just push forward with more medication. While the person with dementia is my patient, I have to care for the caregiver as well. So just like in airplanes, you got to put your own oxygen mask on first. Caregivers have to be in good health, getting sleep, to be able to be there for that person with dementia. And so that, of course, plays into whether we treat, whether we don't treat, whether we focus on nighttime symptoms first or not. Shared decision-making here is important. I have told people that I think we should do X, and they say, nope, I don't like that, and that's okay. We may just agree to talk about it next time. Education is really important. Sometimes I might have been the first person to tell someone that this is a progressive disease that will not get better, and that I cannot make it better, that we can only palliate those symptoms. And sometimes that's really what needed to happen, and maybe the most important thing that comes out of that visit. And then finally, it's important to know that it may take a while to figure out what's effective. I never want people to go away after they see me one time and go, well, the first thing that Dr. Bateman did just didn't work, so we're going to try someone else. You know, I may be wrong on my first attempt, but I try to tell people that so that they know they should let me know how things are going. We may need to go up, we may need to change course. And then, you know, communicating with your provider through a health portal or some form of communication is really key. So that was a whirlwind tour of hopefully dementia related psychosis. Just some thank yous to the Alzheimer's Disease Research Center here at Wake Forest, and then some hopefully pictures to put everybody in a good mood of my family. So let me see if I can answer any questions. I probably won't be able to answer everything, but if Lisa, if you saw some particularly common ones.
Dr. Bateman, so a quick one would be, if someone is talking to relatives who are passed away,
Yep.
Would that be a hallucination or a delusion?
It could be. It would depend on, you know, if they're seeing someone who's passed away, that's pretty common. They may think they see their uncle or their dad. If they're seeing them, then yes, that would be a hallucination.
Okay. And we have heard anecdotally that surgery can precipitate the onset of some dementia.
Yep.
Or exacerbate dementia symptoms. Have you heard of that specifically for LBD?
Yeah, so LBD is, I think of LBD as I sometimes tell patients that, you know, Alzheimer's disease is kind of like steering the Titanic. Things don't move quite as easily with medicines. They're not quite as sensitive. LBD it's so sensitive to changes to medications. Very, very low doses of medications may have an effect in Lewy body dementia. And so that's sort of a roundabout way of saying, yes, I see that in LBD. And in fact, with that delirium onset, if it's of prodromal DLB, if it's particularly prolonged, particularly bad, it may jog me to think of DLB as an underlying diagnosis. An important point, I think, is that people will often come in and understandably say, well, the surgery caused dementia. And the surgery can cause some temporary cognitive changes, but in many people that I'm seeing, it's probably more correct to think of the surgery as unmasking a process that was already ongoing and would have presented itself, but the surgery is kind of a stressor that unmasks a bit earlier. Oh, Lisa, I can't hear you. Let me.
Sorry, can you hear me now?
Yes.
Okay, is there any research in what it will do for healthy people to take cholinesterase inhibitors?
Yeah, there's been people have tried, people have looked at that, and the best answer right now is that it just doesn't seem to help. There's no real protective benefit. It's no data to suggest that it's going to prevent someone from developing cognitive impairment. There is, relatedly, sort of the flip side of that, there's research that's been accumulating about the potential dangers of taking anticholinergic medications over the life. So things like Benadryl, things like Ditropan, that list that I showed you there, it does seem to maybe be associated with an increased risk of later dementia.
Okay, good to know. So we should not take our Benadryl tonight before we go to sleep unless our allergies are very bad, I guess.
Yeah.
All right. Have you heard anything on research for probiotics for people living with dementia? Helpful or harmful?
Yeah, so there's a lot of ongoing research about the microbiome. So that's this, all the bacteria that live in our gut. There's nothing to the point that I would say clearly we have an intervention here, but there's lots of ongoing research. Our colleagues at Duke have a very large grant that's across multiple sites looking at the microbiome in dementia. And so I think that, sort of stay tuned for that. Let me just make one point, because I definitely, when I showed that quote about risperidone and Lewy body dementia, let me just make the point that is an incredibly unusual thing to do. And the reason that I put that up there is to show that for that person, for that patient with that, with their dementia, having tried everything, it happened to be the one drug at low dose that did the trick for them. So I am not saying that risperidone is the first, second, or third line for any of this. I want to be super clear there, because the last thing I want is, Dr. Bateman said risperidone for LBD. Absolutely not. But what I'm saying is it's really complicated to treat these conditions, and sometimes carefully thought out, slow trials, if it's a really persistent and disabling symptom, can yield surprising results.
Thank you. Thank you for sharing that. Yeah, we always encourage everyone to speak to their physicians about any advice they've been given. So what works for one person may not work for another. So we don't have time to get through all of the questions, but we appreciate everyone being on. And Dr. Bateman, thank you again for joining us today and sharing. We are going to take a quick break now, and it is 11 o'clock, and we will be back at 11:15 with Dr. Heidi Roth, who's going to speak on sleep dysregulation and Lewy body dementia. Thank you again, Dr. Bateman. We appreciate it.